Welcome, everyone. Special grand rounds today. We have Dr. Veith, chair of our department, who is going to be speaking to us. Dr. Veith is a Seattle native who spent his academic career at the University of Washington School of Medicine. He received his MD in 1973, which was followed by an internal medicine internship and psychiatry residency. In 1977, he joined the faculty of our university Department of Psychiatry and Behavioral Sciences and was based at the Seattle VA Puget Sound Healthcare System. He became the director of the Geriatric Research, Education, and Clinical Center in 1987 and was appointed UW professor in 1989. He moved to the UW Medical Center, where he was appointed chair of the Department of Psychiatry in 1998. From 2003 to 2006, he served as president, UW Medicine Physicians. In 2011, he was appointed by the U.S. Secretary for Veterans Affairs to chair the VA Geriatrics and Gerontology Advisory Committee, a congressionally mandated oversight committee for the Department of Veterans Affairs. Dr. Veith has conducted extensive research on the treatment of depression in patients with heart disease and stroke and investigated the effects of aging, major depression, and antidepressants on sympathetic nervous system function in humans. He is active in community efforts to improve the quality of care for the seriously mentally ill, and with his faculty colleagues is implementing regionally, nationally, and internationally innovative and highly effective models of care that integrate medical and mental health care. In 2012, he received a 4-year grant to explore the effectiveness of psychiatric and pain medicine and opioid use consultations delivered via telemedicine in rural clinics in Washington state. He recently visited Kenya and the University of Nairobi and will visit South Vietnam in August in an effort to expand the department's global mental health programs. His presentation today will focus on what he learned in Kenya. Welcome.
Thank you. Thank you so much. I've actually really been looking forward to doing this, as you'll see in a moment, for a lot of reasons. I want to welcome you all for coming and welcome my colleagues at the university who I think are trying to watch this on a webcast. And I was afraid I'd be locked out of my office if I didn't thank Miranda and Marie and Andrea and give them a shout out, so I've done that now, so I'm probably safe to get back in my office. Some of you may know that the university determined about a few years ago that global health would be one of its top 3 institutional priorities, and the School of Medicine's had a very long history in doing global health activity, and some of you know that our department is beginning to cultivate a portfolio that's really quite exciting and very impressive. I've been helping to promote that and letting myself get pulled along into the jet stream, and that's really what this particular talk is about. So you'll hear some, gee, what's the state of the art in terms of global health and mental health? You'll hear some issues around clinical care and clinical care delivery models. You'll hear some travelogue sorts of things, some swan song sort of things. So you're welcome to tune in to whatever part seems most entertaining to you. Let me see if I can get this all working. There we go. I think I may need my glasses, so we'll see. So the first question you might have for us is, well, why Kenya? Well, it turns out that we have a very long-standing relationship in the School of Medicine with the University of Nairobi. And this goes back to the early 80s when one of Dr. King Holmes, who's the chair of the Global Health Department that spans public health and the school, and several of his colleagues really discovered HIV in Southeast Sub-Saharan Africa. And since that time, there's been a constant shuttle back and forth of their colleagues and our colleagues. 140-some of their faculty and trainees have come here for masters or PhDs in epidemiology and other sorts of related fields. And an equivalent number of our people are constantly going back and down there. We're sort of the new kids on the block in terms of mental health, and you'll understand why in a moment. The specific vehicle that got us down there was a grant that Jürgen Unützer has with Dr. Mathari Courtyard, who's a psychiatrist down there, sponsored by NIMH, directed by Deepa Rao, who's a psychologist whose primary appointment is in global health, but she's the project director here, and she's about to get a joint appointment with us, and I think she's going to be working in one of our clinics. Lovely person. And this is a picture of some of the people on our first visit down there. There are a couple of people you might recognize, Stephen Vanoy and Ann Vanderstoep, who are both on our faculty, and we'll talk a bit more about that. So this particular project was, again, the kind of excuse for me to begin to make a presence known down there myself, is designed to do research development among their faculty and trainees in the medical school at the University of Nairobi. There are going to be a series of actual 2-week site visits. The first one was in January that I attended. There will be one scheduled in October and a couple each of the next 2 years. They've been working with the talent down there and determined that there are 3 main topic areas where we have particular strengths that seem to be coalescing around some of their needs and their strengths around gender-based violence, PTSD, and Deb Kaysen in our department is the local mentor sponsor for that. Maternal health and child outcomes, Nancy Grote in the School of Social Work, and Ann Vanderstoep, whose picture you just saw in our child division, are heading that up. And substance abuse, HIV, again, Deepa and Dennis Donovan in our department. And they're doing such things as monthly Skype calls from right over here at the 9th and Jefferson building with some degree of excitement every time they do that, to actually continue to work and develop on projects. Hopefully they're going to not only train people up to do research, but end up with some projects and some papers out of this as well. So what I want to do is give you a little bit of an overview of my trip down there and what we hope to achieve in the course of today. In the next 45 minutes or so, I want to talk about the global burden of mental health disorders and the new data that are emerging that make this very compelling. Talk about, when I went down there, I wanted to be really careful not to seem like, the patronizing USA people coming down to tell them what they need to do with their healthcare system. As you all know, particularly here at Harborview, we have enough problems of our own. So I wanted to characterize what our current state of the art is and identify some of those challenges as a backdrop for talking about what we perceive to be some of their opportunities as well. We'll talk about the integrated care model, which has really been developed here and is being exported nationally, accelerated by healthcare reform, and also now internationally through these efforts. I'll describe briefly some of the current challenges in Kenya itself. I'll then flip into the roadshow part that some of you will enjoy, and then I'll talk about where we're going to go next as we move forward. So I want to start real high, and then we'll drill down and go back up high and kind of drill down again. The World Health Organization is increasingly interested in the overall impact of mental health issues around the world, but actually they've been paying attention to this since they were formed in 1948, and their definition of health is health is a state of complete physical, mental, and social well-being. So mental is a very big part of this, not merely the absence of disease or infirmity. What's interesting, as you'll see, is the data are beginning to emerge that show why this is now so important. Many of you may know we have here at the University of Washington in the School of Medicine and the School of Public Health a very important national, actually international research center run by Chris Murray, the Institute for Health Metrics and Evaluation that is funded by the Gates Foundation. His group has been doing since 1990 a serial assessment of worldwide illness and contributions to illness. You should go onto their website at some point. They've got remarkable tools and remarkable sort of graphics that kind of show you agricultural changes, healthcare changes, and many, many things that are just wonderfully amazing to look at. They just published, before my trip in December, a whole series of papers on the latest 10-year analysis of the international burden of illness and disease data. And what's emerging is a very important pattern that's going to be relevant to what we're doing and what you're all doing. And there's really a broad shift away from the traditional acute, mostly infectious disease, maternal infant care contributions to death and disability to, as some of those become better managed with better treatments, and the gradual aging of the U.S. and the international communities, a shift really more to mental health issues and their contributions for long-term disability. They have a way of calculating this called dailies, which are disability-adjusted life years, and through a very complicated weighting and other mathematical modeling capacity, are able to determine a predictable and reliable measure they call years lost to ill health, disability, or early death. And in the period of time from 1990 to the most recent analysis through 2010, there's been a 37% increase in the contribution of mental health and behavioral health disorders to the daily calculations, a corresponding 37% increase in the years lived with disability, or the YLDs, which now represent 23%. So let's drill down into that a little bit and see what this represents. Most of the mental health contribution that's making such an impact is depression in its various forms. It accounts for 10% of the years lost through lived with disability. It ranks number 2 after chronic back pain, so it's quite prevalent, very important. And interestingly, it has 3 times the impact in terms of frequency of a contributor than diabetes, which, as you know, is a very common disorder, 8 times heart disease, which is also very common, and 40 times cancer. And you can see right there part of the calculation. If you get cancer, the probability you're going to live a long time is somewhat reduced compared to maybe being depressed and living a long time. And that's part of the problem. So these are common disorders. They often begin early in life. Therefore, they can be long-standing, and you don't usually die from them, although, of course, we know we have significant risks in there as well. If you look at the analyses from their studies, from an earlier analysis in 1999 and what's projected out to 2020, you begin to see this dynamic shifting in pattern away from the infectious early onset, related to mortality with infant care and delivering babies, diarrhea, to the more classic chronic illnesses. And unipolar depression is anticipated to be number 2 by that time as well. So we have a large international challenge before us. The question is, how do we develop an approach and develop the workforce to be able to manage that, not just here, but I'll talk here first and then we'll move into talking about other parts of the world. Vikram Patel was recently here. He's probably one of the best internationally known psychiatrists doing global health work. He's based in London. He was just here 2 weeks ago. He's on the board for the institute that I just mentioned, and he spent a day with us visiting. He's a good colleague, close colleague of Jürgen's, and actually wants to develop a closer working relationship with us. The other person, by the way, who's also also very well known, is Michael Phillips. Michael Phillips was a resident at our department in the 80s. He's spent his whole life in China. He's going to be coming back as a special invited lecturer for the School of Public Health in the fall, and will do something with us as well. So that's very interesting. So this is one of Jürgen's favorite slides. You can see by the color distribution the challenges that much of the world faces with access to mental health care delivery, and this quote that there are more psychiatrists in San Francisco than all of Africa. So put it in a bit more local, relative number you can understand. Here in the Seattle area, we probably have 1 psychiatrist, and these numbers are for psychiatry, but they translate equally well to psychologists and social workers and other mental health specialists. Maybe 1 psychiatrist for about 7,000 people. In the WAMI region and other parts of the rural parts of the United States, maybe it's 1 per 25,000. As you can see, sort of dropping down the list, in Kenya it's 1 per about 1 million. So right there you see there are tremendous challenges in terms of specialist workforce availability. So why is that? Why do we have, even in the United States, such a disproportionate number of patients with need and limited access to care? Well, as you know, there are a number of reasons. Mental health care and mental health itself has been stigmatized and marginalized for a long, long time. That's been reflected in the U.S. healthcare reimbursement systems that tend to overvalue, acute care, incidents of care, interventional sorts of things, rather than chronic care management. Our patients have often been marginalized, often to settings where they don't have access to care, and as we have very important projects going on here with Mark. I don't know if Lydia Chavasiak's here, but we know that those individuals with chronic illness who are in our mental health center or other mental health centers, because they've been isolated from routine medical care, die 20 years younger than they should. And it's not just from downward social drift or suicide. Those things happen, of course. It's due to simply not having their blood pressure taken care of or their lipids taken care of or their diabetes managed. And that's a consequence of the segregation and the stigma that we've experienced in our own country related to some of these issues. The little pecking order chart is actually pretty well represented in my own family. This might be my brother, Rob, the orthopedic surgeon, with whom I'm going to Vietnam in the summer. My son, the anesthesiologist, is probably somewhere in here, chirping away. Psychiatry is somewhere in between here in terms of its national historical presence reflected in reimbursement and absence of stigma. That's changing. My brother's getting very nervous, but that's okay. Long overdue. So how do we deal with these challenges that are reflected in these sorts of numbers? So we really have very poor access to mental health care, especially for those who need it the most. Our insurance programs are pretty variable and often inadequate or simply don't exist for people who need it. As I mentioned, our access to medical care for those who have chronic, serious psychiatric illness is pretty marginal. We have traditionally not been, as a field, advanced in adopting evidence-based scientific approaches to care. American psychiatry had a fascination with psychoanalysis for 70 years. That's a wonderful discipline and a wonderful methodology, but it's not one that maps well to public health needs and caring for large populations or anybody who doesn't have a lot of resources. And it wasn't one that inculcated in its own application a lot of scientific rigor over those many years. It wasn't until the 70s and 80s we began to adopt more scientific approaches. But now we do have, in fact, very good evidence for our outcomes. And stigma, of course, has remained a constant problem. So we all are living through a remarkable, whether you see it yet or not, transformation in care and transformation in mental health care. One of the downsides of getting old is you get old. One of the positive sides is you can look back and see trends that I'm getting a couple smiles over here with my colleagues. We are in a very remarkable time, and I think that's going to be particularly true for psychiatry. This slide illustrates the last big epic of transformation that I think we could say is a big one in the 60s when we first began to develop medications and then developed as a society a policy to try to get people out of institutional care. And you see the remarkable drop in institutionalized individuals over the period of 1950 to 1997. We don't have time to talk about, they went out into the streets and the communities and maybe we didn't resource the mental health centers as well as we should have. But nevertheless, that was a major transformation in how we've approached care. I think the last 30, 40 years with our development of evidence-based care and more scientific rigor represents the legacy of these continued advances. And we're about to now hit a huge wave of additional change. What's promoting this and accelerating this tremendously, and this isn't just true for psychiatry, is the healthcare reform in the United States. And again, I'm focusing first on the United States. The focus on the triple aim for better health, better quality, and reduced cost is transforming how systems of care and payers are beginning to think about how we approach delivery of our care. We're shifting away from the traditional incident, procedural, right shoulder, left shoulder sorts of care to more holistic, patient-centered, integrated, comprehensive care that has to be more attentive to outcomes of illness and populations and public health, whether it's a small community or a small clinic or a nation. And that's a major shift in how our care delivery systems are going to be working. As you many know, UW Medicine has determined that we will be an accountable care organization by January 2014, and we'll talk over time more and more what that means. We, as a department, for reasons you'll see in a moment, found ourselves at the front end of this wave of this really feels like a tsunami at times. Part of it is we have now the benefit of 40 years worth of really demonstrating effective treatments, although in some ways we've stalled also, and that's a problem. But the the convergence is happening that's forcing us to get into the primary care settings is beginning to have the reverse effect too. We're getting medicine into the chronic mental illness settings as well, and that's going to help bring psychiatry back into mainstream medicine and help destigmatize, and also I think changed remarkably how all this is sort of managed financially. We're seeing it now. So the one question might be, well, why are we kind of out there at the front of this wave, which I think is actually true. These are some of my colleagues who have been kind of spearheading some of this work. Wayne Caton here for 30 years has been doing work that has been looking at developing these methods and models, comparing them to usual care, and now with the help of all of these colleagues, Wade Bentham, Diane Powers, Mark Avery, there's Andrea, another shout out to Andrea, Jürgen Unützer, and others, and Anna Ratzlaff, are really now in a very organized way helping to promote this. We've become so large in terms of portfolio, we've actually decided to create a division that we're calling the Integrated Care and Public Health Division, and we'll talk about why. So when I went to Kenya, I wanted to tell them, look, we have challenges as well, and also to point out to them we are ourselves in a very rural part of the United States. And I think, frankly, that is the major reason why we found ourselves out in front of this. We don't have the luxury of creating a center in a highly dense part of the country in the Northeast Corridor or even Southern California, expect people to come to us, get their day-long or 2-week evaluation, and give them their recommendations, send them off, have them kiss our ring. We don't have an opportunity, mostly because of the geography. So our institution, besides the fact that we are the one medical school for 5 states, has always had to be thinking about how do we get care out there. So I think that really has been a promoting factor for why we find ourselves doing these sort of things. I wanted to show some of the geography to the people in Kenya. I had to get even a bigger, higher view here because Alaska is part of our whammy too, and I wanted to have them get an appreciation for the huge expanse of rural areas that we have some degree of responsibility for. So the traditional mental health care delivery model doesn't work terribly well. First of all, very few people who are diagnosed with illness in healthcare systems actually make it to psychiatrists or psychologists or trained social workers. But the capacity to scale up when you have a little storefront office and you have your favorite patients coming to you repeatedly and you fill up your panel with your 12 favorite or 40 favorite patients doesn't map to taking care of a larger population. And that's one of the limitations that we're really beginning to see changing. Now I'm going to spend a moment talking about integrated care. This is a term that many of us know about because we kind of live here and have been doing this. Some of you are going to be increasingly getting exposed to it. We have medical students here as you start to rotate through the network clinics, the Harborview clinics, and the whole state of Minnesota. If you happen to go work in Minnesota, we'll be getting some exposure to this. And it's really a team-based approach to care as opposed to I'm your doctor, come and see me. Even if you're embedded in a medical clinic or specialty clinic, you're really taking much more of a participatory role in a larger team that's looking really at a population, whether it's the clinic population or the system population, the city or the state or the country. It's really more a team-based approach, very much population-based approach. And many of the principles about managing chronic illness are now have been inculcated into this model. Things that that Wayne Caton saw 25 years ago happening at group health in the care of diabetics and cardiac patients, where you take a care coordinator and you have that person help orchestrate the ongoing care of people. You use a registry so that you don't lose track of people and you have a measurement every time you see them. If you're being followed for your hypertension at group health, or now most places, every time you go and you get your blood pressure measured, you measure it every time. Traditionally, if you're being followed for depression, you go in and we say, how you doing? How's that depression? It's getting better and I'm sleeping a little better. Well, that's good. Keep taking that antidepressant or keep taking that behavioral therapy, that CBT, here's the next session. We don't measure things, and so therefore we get often lulled into a kind of a status quo of, they're a little bit better, and we don't get compelled to make an intervention. These registries also help the care coordinators by knowing that someone, Mrs. Jones hasn't been here for 3 weeks, so I'd better find out what's going on, rather than, only seeing the people who make it to your office. That's more the traditional model. By the fact that you're measuring depression, anxiety, and PTSD every time you have an encounter, you can actually begin to see whether people are getting better and then get inspired to respond if it looks like they're not. These programs are now implementing evidence-based therapies, trained up in the care coordinators, often social workers, are trained up in problem-solving therapy, behavioral activation. They get informed about what does a healthy antidepressant program look like. They get trained to help get people into psychotherapy as well. And this is all now being very actively recognized by the payers and the Boeings and the Microsofts and others who are expecting this kind of care when they begin to make these accountable care organizations. Now, compared to the little Lucy diagram a couple of slides ago, this is obviously a very different sort of model. The traditional model might have been a primary care provider and a patient in their clinic, trying to assess, treat, and manage and follow, let's say, depression or anxiety. The difference here in the model is that there's a care coordinator, a behavioral health care coordinator, working with a consulting psychiatrist, usually at a distance, usually on phone. In my case now, we have this grant doing telehealth, so we're actually bringing in video consultative interactions as well. And it's through that interaction of the consulting psychiatrist getting online, looking at that registry, distilling down. Let's talk about these 6 people whose scores aren't getting better. You can drill down, as you'll see in a moment, and see their curves, and then focus in a stepwise care managed way the attention on those who aren't getting better. They can provide guidance and recommendations that then get transmitted to the primary care provider, who ultimately still has responsibility, and it ends up allowing the care to be delivered in the primary care setting where it's really needed. What's remarkable to watch as this kind of rolls its way through our systems is the kinds of questions we get the first year are, well, is this depression, and what's that antidepressant I should be using? The next year is, which of these mood stabilizers do I add, or what's the next antidepressant to add on in a refractory patient? So you also build capacity in these systems to be able to take on more sophisticated problems. We will always need specialty care, mental health centers, and hospital beds for our more serious patients, but much of the need is in the primary care setting, and this is a model that gets it there. You can't read this, but this is a screenshot of the registry. You can coalesce statistics, whether it's for a care coordinator or a clinic or a state. These are measuring initial depression scores, how often they've been seen, what was the last depression or anxiety score, and over here circled in the red, what percentage of patients after at least 10 sessions are 50% better or not. On an individual level, you can see, you can graph out, well, here's this person's, I think red is anxiety, depression, the other is depression. You can see this particular patient is doing pretty well over time. I was doing this a few years ago as a supervising psychiatrist for a team in South Texas, and it's not too hard at a great distance with a few kind of vignettes about what's going on and then tracking of the outcome to see, oh, I need to do something different. This person was getting better and they plateau off. And it's really that intervention and being able to track these people so they don't just disappear and go away without you thinking, gee, I haven't seen Mrs. Jones for 3 weeks, that makes the difference in terms of more of a measurement-based approach, a treatment-to-target approach. You really kind of get these scores down here and not just saying, that sounds pretty good, keep doing that treatment you're taking. The big evidence and the most important large initial study that showed the impact of this is called IMPACT. This is a study done by Jürgen Unützer. The study was actually done in about 2000. This is a secondary paper that was looking at some of the downstream costs. But they did a large study, I think 1,800 patients in 8 different locations that varied from a Kaiser to a VA to inner city Indianapolis. As you can see, across the board, there was about a doubling of the response rate in the coordinated care, collaborative care approach compared to usual care. And that led to some tremendous, value in terms of patient outcomes, patient satisfaction, reduced costs of utilization of services that has not escaped the attention of the federal government or the payers who are now implementing this, as you'll see, widely. We were approached by the state of Washington about 5 or 6 years ago to do a pilot of this model of care in King and Pierce County in 30 community health clinics, where they were getting patients in who were called GAU, or General Assistants Unemployed, who fell between the cracks, didn't have health care, weren't disabled, so they weren't on Medicaid, they didn't have SSI, and they were coming in for medical care, and they had all these depression, PTSD, substance abuse problems. We began implementation in King and Pierce County, and even though the national economy tanked over the last few years and this program was threatened, it actually went statewide about 3 years ago. We're now in about 148 community health clinics. These are clinics mostly serving underrepresented minorities, relatively poor, not terribly well resourced, who often have all sorts of psychosocial, medical, and psychiatric problems. And the outcomes are really spectacular. A more robust, and that was depression data I showed you a moment ago on Jürgen's slide. Wayne Caton had a paper published in the New England Journal in 2010, something I'm about to send out for the department about, made into JAMA News, talking about a paper last year in the archives showing some secondary cost benefits. In the group health system, in 14 clinics, recruited not just depressed patients, but those who had a combination of poorly controlled diabetes, heart disease, and depression or anxiety. They did a randomized controlled trial of usual care versus collaborative care. The kind of benefits they saw were really across the board. Their hemoglobin A1C levels, their diabetes measure substantially improved, their cholesterol's improved, their blood pressure improved, obviously their heart disease improved, and their depression scores and their satisfaction improved. And there was, over a 2-year period, a $600 savings, which is a lot when you're looking at population-based approaches to healthcare costs. And that's mostly due to decreased utilization, not bouncing into the emergency room, and having secondary consequences for not adhering to their treatment. So we're now part of an $18 million national CMS innovation grant. We're doing the training part, my colleagues in the division, to train up 8 states in the country to deploy this model to, again, try to see its effectiveness in hitting that triple aim. So it really is a movement. It's interesting how well known this is in the family medicine primary care field. It's now beginning to penetrate our own field. 15 years ago, Jürgen and Wayne had an APA, American Psychiatric Association symposium, and like 5 people showed up. Last year, it was the theme for the American Psychiatric Association. It really has become quite apparent. And I think there's some wonderful things about the reintegration that's happening. So it's a snapshot of where we are and the rapid changes that are occurring in our own environment. I gave that as an overview for our colleagues. I presented this at the University of Nairobi. The Minister for Mental Health was also presenting about their challenges. And so I wanted to try to set that up as a backstop for why we were doing this model, to see if it might not be something they would also benefit from employing. So Kenya is in southeast sub-Saharan Africa, as you saw. It's also a very rural area, very poor area. Nairobi is down here. They have only a couple of modest-sized cities, and most of it is really quite small towns. There's obviously, as you know, some of you, there's been some degree of turmoil politically there the last 5 or 6 years as well. Their most recent election didn't have the outcome the United States wanted, but at least it wasn't as dreadfully turbulent as the one that preceded that. Little snapshot about what do they have and how are they approaching it. So they have a population of about 40 million, relatively young. Half the population is younger than age 18. Their service is very kind of organized into 6 levels. They've got national referral hospitals and provincial hospitals, and I'll talk in a moment about a provincial hospital that the University of Washington is working in. Their mental health care, not surprisingly, because it's a very poor country in many ways, is managed and delivered by the government. There are 4 major psychiatric referral hospitals: Mathari, University of Nairobi, one called Gilgil, and Moi. And I'll show you Mathari in a moment. As soon as you get out, well, anywhere throughout the country, most of the care, if it's given by a specialist, is by nurses, but most of the care is really kind of haphazard. They're at the community and the district and the tribe level. It's just really under-resourced. It's pretty remarkable. In the whole country, in all of these settings, there are about a little over 1,100 psychiatric beds. To give you a relative sense of that, that's about a half a bed for 100,000 inhabitants, or 1 per 200,000. For us, it'd be 28 for 200,000. It's been estimated that what a country really needs is about 50. As we know, we don't have enough beds either. And at least in 2005, Britain seemed to exceed that. So they have very few focused psychiatric inpatient facilities. And even if they had a 20-bed unit in most of their district hospitals, they would still have most of their patients being unable to kind of access them. What about their workforce? Well, they've only been training psychiatrists in the University of Nairobi since 1982. They have a very small class. It's like 6. They're very, very well trained. It's a British sort of system. The number of psychologists is even smaller. They've only been training them since 2000, and social workers even more recently. There were only, at least at the time we were there, 79 psychiatrists in the whole country. And 21 of them were in the university system. Many of the others were in the ministries, so very few of them were actually out in delivery care, and there were some private practitioners in, again, Nairobi. So, of course, most of the care has to be delivered by non-physicians. There are only about 250 mental health nurses working in the actual delivery of care at the provincial and district level. And it's way obviously under-resourced. And most of the people beyond the nursing level really have very little formal training. It's been systematically reviewed and studied. They too are going through healthcare reform as well as political reform. They began this in earnest in the 80s. In 1989, they formed a Kenya Board of Mental Health, which was the first time they had one in their ministries. By the 90s, they had a blueprint for where they wanted to go, really try to get more care out decentralized, which should sound a little familiar because that's kind of what we're doing and had been doing. And that they've actually been up to visit and been out to Boise and looked at the whole whammy thing as a possible model for them. In the mid-2000s, they began to get a bit more organized and began to determine they really wanted to get mental health care capacity a bit more out into the community setting. They developed for the first time actually an essential list of drugs that at least the provincial and the district hospitals had to have. Before that, it was pretty haphazard, and even this is not up to the kind of standards we would expect. Very few of the newer antipsychotics, if any, they're using amitriptyline or Elavil. They're using a lot of thorazine. They're using a lot of barbiturates. They can't even use lithium in a lot of places because you need to have a blood level to be able to do that. So the access to medications is pretty limited, and that's even at the highest levels of care. It is important to know that they're really moving as a society to try to address these issues within their constraints of the politics and the finances. But mental health is built into their constitution as one of the Bill of Rights. So their little snapshot of challenges looks not too different from ours. They have tremendous demands that exceed their capacity. They're shifting away from they're doing a little bit better job, but they still have tremendous challenges around HIV, clean water, other kind of basic necessities. They are a relatively poor country and one that's still quite early in its development as a democracy, and as a consequence, things are still very much emerging. They have a very limited mental health workforce and clearly still struggle, as we do, with some of the impact of stigma. Now, what's interesting, I'll go back up to the 40,000-foot level. There is a global appreciation of the World Health Organization about how to take the now well-developed evidence-based treatments and modify them and deploy them into under-resourced areas. This is a snapshot of their mental health gap intervention guide that's available online that really would be kind of a manual for, how would you treat bipolar illness in a setting where you really couldn't use lithium? How do you treat PTSD in the sexually assaulted, war victim population? So we know how to do some of these things. It's largely through a focus on what's called task shifting, which is sort of what we described here in our model of the integrated care, where you complement and support the care coordinators, the primary care physicians, as a way of expanding capacity and access. There will always need to be some facility for and capacity to take care of the long-standing, serious, chronic mental illness. There will always need to be varying degrees of hospital and specialized mental health center community psychiatric beds. The hope is to try to drive as much of this down into the primary care system as possible and use information and training and education to help the communities also do some preventive work. So this is the overall conceptual philosophy. What's interesting is actually, as you look carefully at the literature, we don't have time to go into much detail here, there are now a number of really exciting examples of how you can take something like CBT, or in our own little case here, not little case, important case. So Deborah Kaysen, who's not here, but is here in spirit, just with her colleagues, Dr. Bolton at Hopkins was the principal author, 2 weeks ago, had a paper in the New England Journal of Medicine, and you may have seen some of the press about this. And they took classic cognitive processing therapy, delivered in a group after a single session compared to individual kind of case management support to Congo, and in a war-torn area where 40% of the women have had some exposure to sexual assault, either themselves have been raped or seeing that happen. Obviously, tremendous amounts of PTSD and depression, anxiety, and demonstrated that you could transform the concepts. They translated the forms, the ratings, and the training into 5 different languages and delivered it quite successfully, showing, depending on how you look at the numbers, a substantially greater improvement in depression, anxiety, and PTSD in the group intervention population compared to the more case management, personal support sort of group. And these were people who, the healthcare providers, had some experience. Most of them had 4 years of post-high school training, had been working in the field providing case management or some psychosocial support. They got trained by our distant colleagues, some of whom went there to train people. Next slide. I hit that. As you can see, we're quite successful. So there are several examples like this where we're taking what we know are really effective models in more resourced areas, translating them into culturally competent ways to deliver this in much less resourced areas that are showing great promise, and that's exciting. So those of you who like field trips, I'll give you now a little tour of the field trip. So basically, I presented that. We had a nice long discussion with the dean and the chair of medicine and a few others, and that's going to be a backdrop of our continuing relationship with them. My concern is they're so understaffed in terms of workforce. We really don't have people to connect to out there. So it's going to be a longer process, I think, for them to think about trying to deliver this kind of model. We're going to focus initially on that first project, was a research academic thing. We're going to talk, I think, more about shared training, distance learning, Skyping, and other sorts of things to bring content to them that they don't have easy access to. So we spent a couple days touring at the University of Nairobi, the academic departments, met with the Department of Medicine, the dean, the Department of Psychiatry, in some of their clinical settings. Some of the students here may recognize this is Marcella Pasquale, who's much more famous than I am. That's my spouse. So she was with me. We're here meeting with some of the faculty in the department. And I have to tell you, they are superbly trained. They're really bright. They're also amazingly hardworking. You know, they do 6 things. I mean, they run this unit, that unit. They do research. It's pretty amazing. Lovely people, and really, really a pleasure. We toured the hospital. They obviously have their own problems with gender-based violence, and a very, very nice, soft, discreet, careful program with great sensitivity, kind of helping to get people comfortable coming in and saying, they've got HIV and they've got issues around those issues. And this is a snapshot of their outpatient psychiatry clinic. Again, it's a kind of a brick concrete kind of building. I think you may have seen the first shot of the University of Nairobi. It's not aesthetically particularly contemporary. It's certainly quite functional. What's really remarkable, this is the outpatient clinic staff, a couple of nurses. This psychologist I asked her, well, what kind of therapeutic models are you using? She says, cognitive processing therapy. I thought of you all. And I thought, oh my goodness. So they really are very well trained, and they just don't have the workforce and the capacity to extend it very far. We visited Mathari Hospital. It's the biggest psychiatric hospital in the country. It's also right there in Nairobi. A year ago, if you go on and do a Google search for mental health in Kenya, you'll find your way toward a CNN profile of a Dr. Frank Ngenga, who is quite prominent there, or at least famous there. We're not entirely sure how prominent he is because I think he's pissed off the ministry. But anyway, we were going to meet with him, but somehow it got canceled. So this profile, he's a Kenyan psychiatrist who was trained in London and went back to bring those skills to Kenya, and he has a TV show where he brings patients on, and his goal is to try to destigmatize psychiatry and get it up in the consciousness of the conversation. Well, unfortunately, he had been there in the fall, and the CNN cameras kind of charged through and took a lot of pictures, and then they displayed them. And local people were more than alarmed at the lack of confidentiality, privacy of the patients there. So we had a sense that they were being very careful. We weren't walking around. Well, we were walking around with cameras. We were being careful where we took the pictures. So we had a sense that they had been very careful to try to present this as well as they could. And they were, again, lovely. This is Dr. Kisavuli, who's the director of this mental health of the hospital, his chief nurse, Deepa Rao, again, who met us. And again, it's kind of a formalized country. We always, of course, kind of went through the usual protocols. I want to just give you a feel, not in a critical way, but just give you a feel for what the facilities look like and the challenges they have. It was striking to us, kind of normal for them. This is just a courtyard. These are a bunch of blankets out there drying in the sun. You may have seen in the Seattle Times about 2 months or 3 months ago a 3 or 4 day series on the Kaiberia slum. This is a view of the slum from the hallway walking down between the breezeway of a couple of the buildings. So it's right out there. It's a very stable, kind of interesting place. Actually, there are mental health clinics in there too, but it's right adjacent to the health center. This is Nairobi downtown. This is a patient admitting area in the substance abuse area of the hospital. Again, it gives you a sense of the challenges they have on resources. I don't know if John Newmeyer's here or not. This was for you. This is their ECT room. I show you this in part because this is Mathari Courtyard, the chair of the Department of Psychiatry there, who was lovely and traveled around with us and warmed up tremendously to us. A couple of the nurses. The reason I want to show this is there was a young, beautiful woman, manic patient, who was walking around with us as we were touring here, who the nurses were trying to shoo away. And we could tell she was manic, partly because she had, even in her language, you could tell these were neologisms. She was making no sense at all. But then she told the nurses, no, I'm with them. So a little grandiose. But she was really cute. We couldn't take her picture, but it reminded me of it. She was really sweet. This is their OT area. Again, they don't have a lot of resources. This is part of the treatment setting where they, in their addictions program, and I'll read this for you. It's kind of what's ahead, self-will. It means you keep doing what you're doing. You go to death, jail, and insanity. And this one is decision to accept, lifestyle improved, sobriety, and abstinence. So pretty direct, pretty straightforward, but not the most contemporary sort of resources available. This is a snapshot of the patient room for a couple of the women who were in that program. You can see the nets, mosquito nets. These must be insufferably hot. They put on a case conference for us. This is the chief resident, who was superb. They projected it all. They walked through as a case of a 63-year-old Parkinson patient who probably was depressed and maybe a little delirious. And Marcella and I were asked to comment, and then you can't see him over here, the lead physician who was running this conference, and the room was filled with doctors in training, residents all in their white coats, very formal. And he asked each of the faculty members to comment on this case. And they were social workers, psychologists, a couple psychiatrists. And each one of them sort of blew us away with their kind of assessment and their perspectives. The quality of their training and the expertise of their faculty, staff, where they have them is just first rate. We were very impressed. One of the days we went on to Naivasha Community Hospital. This is the Rift Valley where the migration starts, and some of our team. I won't spend time introducing us all. So Naivasha District Hospital is a hospital that's 90 minutes away from Nairobi. The University of Washington School of Medicine has a chief resident who has spent a year there and one scheduled for each of the next 2 years. They're rotating residents in medicine, not entirely completing the year, but most of the months. Occasional rotating surgery residents. Dr. Gordon Starkeybaum, who's a professor of medicine, used to be the chief of staff at the VA, spent March there. And I had this fantasy before going, well, this will be out there in the savannah, kind of bucolic. I've been to South Africa, and well, this might be good. I'll go after I step down. I'll go spend a month in Naivasha. Well, this is a shot of the street outside of the hospital. It's just like the other big cities. It's very dusty, very busy, quite poor. The drive there was probably the most dangerous thing we did. The roads are not great. The traffic is not great. Every car and truck looks like it's got wire and duct tape holding it together. It was pretty freaky. So it's a very busy hospital. I think it's 450 deliveries a month. It's a remarkably busy place, and it's a happening place. And the house staff there are pretty much on their own. So we may be sending fellows. We won't be sending residents right away. This is their pharmacy. You'll notice that drugs for kids under 5 are free. Anti-malaria pills are free. This is Joseph, and I just lost his name. I'm chasing it down. He's the one nurse practitioner, mental health provider in this whole facility. So he does all the outpatient work, does all the counseling, does all the admissions, does all the detox. And I was teasing him, and I said, well, did they ever let you go on vacation? He laughed at me. And the worry is what happens if he gets sick. He refers patients to, I think it was the Gilgil Hospital, where they have no psychiatrists on the staff right now. So it's pretty much on your own. They showed us some wards that as big as this room, 50 patients in beds that are not much wider than this table, sometimes 2 to a bed, that really demonstrate their needs. I didn't tell you, I meant to. The pictures we wanted to take, we didn't take at the Mathari Hospital were the units or the wards where the psychiatric patients were. And they were all outside in a kind of an enclosed wire and somewhat barbed wire enclosure, maybe 4 times the size of this room, kind of laying around. I mean, they obviously had treatment, and that's where they slept at night, but it didn't, that was part of what was so controversial about some of these pictures they took. I couldn't resist this picture. She gave me permission to take it. She was there for some infant care. Lovely people. So, next steps. We are continuing with this research project to go on down there. As I mentioned, we have several of our faculty who are sponsoring each of those topic areas. We are now beginning to coalesce some topic areas where they have desperate need but not enough faculty, and we'll begin to share that with them. I am going to Vietnam in August. My brother, the orthopedic surgeon, up on the top of that pecking order, has been going for several years doing free foot care. He goes out to North Vietnam and fixes club feet in kids who are 10 or 12 who've been walking around with feet like this because they couldn't get fixed, and essentially transforms their lives. It's pretty wonderful. And my youngest son is going to accompany him with their group, and so I got through the school of social work a recent connection to a medical school, the Con Tou University of Medicine and Pharmacy in South Vietnam in Con Tou, that has a progressive new leadership, woman dean, woman chief of chair of family medicine. They're kind of breaking the mold, and they're actually talking about mental illness instead of hiding away from it. They want to develop a capacity in family medicine to assess, treat, and care for these people, which sounds a lot like integrated care. So we've been kibitzing back and forth as recently as yesterday. So I'm going to drop down and introduce myself and begin to do a needs assessment with them. I've gotten connected with Jim Legerfo, who used to be the medical director of the hospital here in the 80s and maybe early 90s, who's in the Department of Public Health. Has been working in Cambodia now at their one medical school at Phnom Penh for many years, And as he keeps telling me, look, anybody there over 30 has PTSD from the Pol Pot sort of regimes. And I've gotten him now connected to Kanto University, and we're going to begin to try to look at how we can offer some help. So that's sort of what's on the horizon. I'm going to stop there and invite you to ask me any questions. I'm sort of expecting some of the future fellows to sign up and say, I'd like to go to Naivasha. So we'll talk about that. So again, 4 or 5 of our faculty are now getting adjunct appointments in global health, and this will be a growing part of our portfolio. So thank you all for your attention. I have been well. So, questions, comments, advice? Yes, Tom.
Basic question. Is English the primary language as you move through Kenya, these various areas?
Most people, well, in the cities speak English. Most people in the communities, out in the communities, speak either Swahili or most often their local dialect. So it's quite variable. But we had no trouble, obviously, in Nairobi.
Education, that's
Mm-hmm.
the
Yeah.
language.
Yeah. Mm-hmm. Mark?
With the dire shortage of personnel, I'm wondering what's available on the primary care side, because it strikes me that though we have developed our model a little bit differently,
Yeah.
if we did not have some type of mental health workforce, the only alternative would be to work with primary care providers
Yeah.
to learn how to do this while they're building their specialty mental health.
Unfortunately, it's equivalently undeveloped in terms of workforce. Their training has them go through medical school, do a couple years out in one of these district hospitals. So there was this interesting case that the chief resident talked about where someone had, I think actually got munched by a hippo. I think which is one of the most dangerous things in Africa, actually, and had serious trauma. And needed surgery, and the third-year surgery resident was being called upon, and he's saying, looking at the books, I've never done this before. Mm-hmm. And she said, she's having been there many months longer, well, if you don't do it, it's going to be one of the house officers who just got out of medical school. And so they typically, that's how they staff these district hospitals. And then they go back, if they're going to go back, they go back and do their specialty training. So many of them will go off into these smaller communities, and they're pretty isolated. Part of what the university is doing is trying to connect with them to make them feel part of the university, sort of like we are with WWAMI. But that's the challenge. I think in Vietnam, from what I can tell, actually, there's a much better delivery system, at least for primary care, and probably, I'll find out about the numbers, a little bit more larger mental health workforce. But that is exactly the problem. There's really not much to connect to. What I think they need to really begin to do is try to ramp up their capacity to train people, so they're pumping more people out and more nurses and others, social workers and others, not just physicians. But as I was talking to Dr. Holmes, King Holmes was down there, and we had dinner with him, and I was saying, oh my goodness, 50 patients in this room, and they had HIV patients and TB patients in the same room, and he kind of chuckles and looks at me and says, well, welcome to medicine in Africa, he says. So again, it puts things in perspective and gives you an appreciation for the need out there, and I think is a very inspiring way for us to think, we have things to offer, and we need to help our world do that. You should run off and finish your Friday, and thank you so much. It was fun. Okay.